Hi, Dr. Garima here, and we'll be solving more questions related to Australian Dental Council written exam. Like I mentioned in the last video, the good thing is that ADC itself released around 200 questions, or rather 50 scenario-based questions as a practice paper for all the candidates to give them an idea how the actual exam feels like. So we'll be solving each question. Now, see how the paper is made is we have like 9 different specialties, correct, in dentistry. Each specialty has its own subjects and its own concepts. Now, you're required to know that theory. Now, suppose example we take third molar, like what this question is about. Now, third molars can come in oral medicine radiology, it can come in oral surgery as impactions, it can come in periodontics as the inflamed operculum around it. It can come again back to the surgical part of the oral surgery as to how would you classify and what would lead to extraction of it, like how it would be done. Then again, it can jump back to oral medicine as to what medicine are you going to give, and what kind of patient, the patient overall health, and what kind of radiology would you do. So you can take like 4 specialties just on the third molar. Now I can just choose the topic third molar from all the specialties and I will combine my knowledge, okay, and I can form a scenario based question giving you a proper patient, but the treatment of that patient would involve all these 4 specialties. Understood? So you need to know your theory, your all dental 9 subjects very properly, and the topics associated with them, all of which I have provided in the Ultimate ADC Companion book. And then you need to know the guidelines, how the Australians do it, because you're giving an Australian exam. So you need to know your therapeutic guidelines of ADC, again the questions of which I have compiled into comprehensive ADC book. Both these books you can just message me, I can share a sample with you, and if you're happy you can just go ahead and buy it. That would ease out your work in opening the textbook. Like instead of opening the textbooks, you can just go through these books and strengthen your concepts. And once those concepts start strengthened, then you can start solving these questions, correct? Now, solving these questions are also tricky because they are not straightforward questions. They are tricky questions because they want to test your clinical judgment, correct? Which makes them really nice, because these are exactly the kind of patients that you see in your clinic. Especially this question, like I'm sure every month at least 2-3 patients, if you are a busy practitioner, you will definitely find a scenario like this. So you should definitely know how to answer such questions and do the right treatment. Let's jump in to solve the questions. Andrea is a 19-year-old student who presents to your practice with painful, partially erupted mandibular third molars. Okay. On initial examination, like a basic clinical examination, the operculum over the tooth 4-8 is swollen and tender, like you can see on the picture. The operculum over tooth 3-8 also has the same appearance. Now, you also note that the submandibular lymph nodes are enlarged and tender. These are the submandibular lymph nodes. Now, if these are enlarged and tender, that means there is quite a lot of infection which is going on. Andrea's medical history indicates that she is immunocompromised. Now, they haven't mentioned what she has. It just says she is immunocompromised. Basically, her immunity is not that strong. Maybe she has an autoimmune disease. Maybe she has some kind of other disease which kind of compromises her immunity. It can be anything, but they have not mentioned that. So what this question tells you, it's a young patient. It's a young patient with not a great immunity. So any procedure which is going to involve certain amount of surgery or invasiveness or blood loss, etc., you will have to give antibiotics because healing would be compromised. If it's a healthy patient, then you generally don't give antibiotics. But if it's an immunocompromised patient and you're going to have a blood exposure, that means the outside bacteria can also directly enter the bloodstream, then you need to make sure that the patient doesn't fall severely sick because of your procedure. So you need to give antibiotics to protect the patient. You understand? Because especially in patients who are immunocompromised or at a risk of infective endocarditis, correct? So this is what you understand from the question. Next, her submandibular lymph nodes are also tender. That means infection has spread quite a lot. So like the patient needs to be managed as soon as possible, basically. Now let's see what we can do about it. What is your recommendation to Andrea as the most appropriate mouthwash as a part of management of a painful wisdom teeth? See, because her lymph nodes are swollen and tender, that means the infection has spread to them. So first thing is that you need to manage this. You need to reduce the infection, and then you will schedule your surgery. So your surgery is scheduled at least a week later, not before that, because that is the amount of time it would take if you start any antibiotics for the patient to settle the infection down to a certain degree. Because right now everything is so painful that nothing is gonna work, like the surgery aspect of it. So till that time, what are you going to recommend her to manage? Most appropriate mouthwash. Most appropriate. Most means you have to pick up one. It means all the options given can be correct. Essential oil. We don't prescribe oil as a mouthwash. Povidone iodine, that's betadine basically. You can, but technically not a mouthwash. More like an irrigation substitute, you know. Hydrogen peroxide solution can work, but it's gonna be a little strong. Chlorhexidine gluconate, that's a standard mouthwash it's available and it's amazing, and it's not causing any burning or sloughing of the tissues that hydrogen peroxide may cause. Sodium bicarbonate, not a wrong answer technically, but if I have to choose the most appropriate mouthwash which is easily available and equally effective, then the answer is chlorhexidine gluconate, 2%. 0.2%, sorry, 0.2%. 2% chlorhexidine gluconate you use as a root canal irrigant solution. 0.2% chlorhexidine gluconate is what is available out in the market, and that is the one you are going to ask her to use it. You subsequently prescribe penicillin for Andrea, and the following day she presents to your practice again complaining of an itchy rash all over her body. She got allergy, right? After advising Andrea to stop taking the penicillin because clearly she developed an allergic reaction because of it, what is the most important thing to do next to manage her reaction? Option A, give her adrenaline. When do you give adrenaline? Immediately, when the patient takes the medicine and they have severe bronchoconstriction and vasodilation, anaphylaxis basically. That is the time you give adrenaline. It's an emergency drug. She is well conscious. She just has rashes. There is no mention of any bronchoconstriction that is happening. So you're not going to jump to the emergency medicine, adrenaline. That would just create more problems. So you're not going to give her adrenaline. Prescribe her amoxicillin instead of penicillin. Amoxicillin is penicillin, isn't it? So no, you're not going to prescribe that. Prescribe her systemic steroids. Steroids, why? No. Prescribe her antihistaminics. Yes, that is the answer of choice. Antihistaminics are anti-allergic basically. So because it's a mild allergic reaction, rashes are just a mild form of allergy. If there was anything more than that, when would I give her steroids? If I had not even systemic steroids, I would give her inhalational steroids like salbutamol if she was displaying signs of respiratory distress, but she's not mentioning that. So option A and option C are not of choice. Option B, amoxicillin is still penicillin, so I'm not going to give that. Oral antihistaminics is the right option. You won't even prescribe IV antihistaminics. You'll give her oral antihistaminics, okay? Now, what radiographic modality is indicated as a first choice in planning for removal of a mandibular wisdom tooth? Now, this is a question which has been asked many times in the exam, okay? Now, if you see the multiple choice questions, you will realize that the sub questions are nothing but basic MCQs. It's like 5 different MCQs on the same subject has been clubbed to form one scenario. You understand? So your basics have to be very strong. First choice in planning for removal of third molars is always OPG. Advanced modalities are CBCT. Many of the candidates directly jump onto the answer of CBCT because they say, when we have this option, why shouldn't we take this? This is not the first choice. This is an advanced choice. Okay. CBCT is taken to see further anatomical structures. Yes, you may have CBCT, doesn't mean you just opt for one directly. The first choice will always be something which is minimally invasive but gives you the maximum results of any test that you want to do it. So panoramic radiograph is the correct answer. CBCT is an advanced modality. Periapical radiograph, no, there are two molars, and plus periapical radiograph won't give you the exact location of the inferior alveolar nerve. Occlusal radiograph also, it's not going to help you. These are not the first modalities. You may choose to take this for any additional information on that particular tooth. But when you say a third molar, it has to be a straight OPG. There is no questioning about it. It's followed worldwide. It's mentioned in the guidelines, and the answer key here also mentions panoramic radiograph. So do not get confused because you feel CBCT is better than OPG. Yes, it is in terms of visualizing the anatomic structures, exact location, but it's an advanced modality. It's not the first choice. Understood? Now you plan to remove Andrea's lower wisdom teeth as an elective procedure, not an emergency procedure. Elective means nobody is in a state of urgency. Both the patient and you are determining a date, time, and planning for the procedure. That's called as an elective procedure. Andrea's treating doctor has advised that she requires surgical antibiotic prophylaxis for her wisdom teeth. Andrea's treating doctor, meaning what? Her general practitioner. Okay. Her body is treated by a general practitioner. Only the teeth part is treated by you. You are a dentist, not a doctor, right? Many times you must have heard that. And yes, it is true. You are a dentist, not a doctor. A medical general practitioner is what I mean. Andrea's treating doctor has advised that she requires surgical antibiotic prophylaxis for her wisdom teeth extraction. Now, I want you to understand here two terms very, very carefully. There is something called as prophylactic antibiotics and there is something called as therapeutic antibiotics. Many times, many of the candidates get confused amongst these two terms and hence mark their answers wrong. Let me give a very simple and clear explanation to you. If you are making notes, write this down. Prophylactic antibiotics is to prevent an infection. The dose that you will give is different. Different than what? Different than the antibiotics you will give to treat, say, a swelling or an infection. You understand? The duration of this antibiotic is different. So let me simplify further for you. Example, you get a patient with a big swelling, a frank pus, there's an abscess, the tooth is having irreversible pulpitis. The patient came to you with these symptoms. Okay, the medicine that you're going to prescribe him, for example, say you are giving augmentin, that's amoxicillin plus clavulanate. That is called as a therapeutic antibiotic because you will be prescribing to that patient for a period of say 7 days and the dose would be according to the weight of the patient, which can be either 1 gram or something for an adult, correct? So you will tell the patient take this medicine 2 times a day for 7 days a week, then you come back. Why have you given this medication? So that the swelling, the inflammation, the pus all goes away. The antibiotic that you gave is to treat an infection. That is called as a therapeutic antibiotic. The dose of which and the duration of which is significantly longer. Like the dose, say 1 gram, and the duration is 7 days. You understand these two things. Now let's come to prophylactic antibiotics. What is a prophylactic antibiotics? Prophylactic antibiotic you are giving in a patient where there is no active infection at the moment. The patient seems to be okay on that day. And you will give this medication just once or maximum 2 times. And the dose of this will also be a little different than what you have prescribed to treat any particular infection, or the dose may be the same, but the duration will not cross 1 or 2 days. You understand my point? That is called as prophylactic antibiotics. It's to prevent an infection from happening. It's not to treat an infection. So easy way to remember: therapeutic, T for therapeutic, T for treating an infection. Prophylactic antibiotics, P for prophylaxis, P for prevention of an infection. Understood? Read the question. If it's saying you are giving a prophylaxis, it has to be just 1 or 2 doses, and that to 1 hour before the procedure. If the question says therapeutic, it has to be like 5 to 7 days, 2 times a day or 3 times a day, depending which medication you are giving. You understand? After listening to this explanation, if you still go ahead and make a mistake in these 2 terms, you are only responsible. Understood? So now let's go back to the question. Which surgical antibiotic prophylaxis, understood, regimen would be most appropriate to prescribe Andrea? Prophylaxis. I'm looking for an option which just mentions 1 dose or 2 doses. Understood? Ampicillin 300 milligram 1 hour before surgery. Wait, don't jump. Isn't the patient allergic to penicillin? Am I going to choose ampicillin? Clindamycin 600 milligram 1 hour before surgery. Yes. Metronidazole 400 milligram 1 hour before surgery and continue 12 hourly for 5 days. No. 5 days, we don't give prophylactic medicine. Erythromycin 500 milligram 1 hour before surgery and continue 6 hourly for 10 days. No. Again, 1 or 2 doses. Amoxicillin 500 milligram and clavulanic acid 125 milligram 1 hour before surgery. Beautiful dose. Isn't the patient allergic to amoxicillin again? Correct? So option A, B and E are correct. But since the patient is allergic to penicillin, I'm going to go with option B, that's clindamycin. Understood? This is how you solve the question by reading the keyword properly. Had you not read prophylaxis word, had you forgotten that the patient is allergic, probably you would have gone and chosen either option C, D or E, correct? Correct? This is how you make mistakes. And then you wonder, how did I fail in this cluster? Because of this mistake. Because you went too ahead. You were too fast in reading the question. You did not process. We have to filter out 2 factors, correct? Let's go to the last question of today. The next appointment Andrea can attend to have her mandibular wisdom teeth extracted is 2 weeks away. What is the most appropriate local management? Local, not systemic. Local means something you're doing inside the oral cavity, not giving something to drink. And that can be provided to Andrea in the interim. Interim means during the procedure, during the interval between the appointment of today and the elective procedure that is scheduled 2 weeks later. Local debridement of the operculum and irrigation with 1% hydrogen peroxide. Yes. Excision of the inflamed tissues around the mandibular wisdom tooth. No, if you excise, you're going to have a blood exposure. You're going to have a blood exposure. The patient is immunocompromised. You can't risk that without giving a surgical antibiotic prophylaxis. Pain management with paracetamol and ibuprofen. Technically correct, but then that becomes a systemic option. It's not a local factor, right? And the question is asking you about the local management, not the systemic management. So option C, even though correct, doesn't fit as an answer to the question that is being asked. Advise Andrea to rinse with warm salty water at home. Yeah, that can be done. But the most appropriate, that's the question, right? Not just an appropriate, most appropriate. So option A and option D are correct, but most appropriate is you personally debriding that operculum area, because inside the operculum the patient is not able to clean, and any plaque which is there inside or any food lodgement is there is further going to aggravate the gingival inflammation. So you personally are going to debride all that thing and irrigate with 1% hydrogen peroxide. Understood? So that is your answer. So this is how you solve. These MCQs are all given in different specialties of dentistry in their own respective textbooks. And definitely questions will be asked upon third molar, either their classification or their radiographic stuff or something like this. And we'll have to answer them. So very important question and a very nicely structured question. Again, all these MCQs are mentioned in my Ultimate ADC book. You can just go ahead, email me, and I am happy to share the sample copy of that book. And have a nice day. See you tomorrow with another question.